So hello everyone, and welcome back to our new Young ESGAN webinar session. And today we are going to talk about nutritional management of eosinophilic GI disorders. We are going to wait just a couple of minutes just for everyone to join, and then we will start with a short introduction about Young ESGAN, and then we will go straight to our presentation of today. So we will just wait just one more minute, if that's okay. Okay, so I can see that many of you already joined. So because our time is limited, we only have 1 hour, I think that we should actually start. So hello again. My name is Mara Ionescu, and with my colleague today, Jose, we are going to moderate today's webinar, and we are going to talk about the nutritional management of eosinophilic GI disorders. And we have a special guest, Dr. Carolina Gutierrez Junquera. So I will start with a short introduction about Young ESGAN. Just a second. Okay, and who we are and what's our committee mission. We want to promote high quality research and training for our trainees, and we like to organize different activities for our young members, but most important, we want to represent our interest and the interest of the young people within the council and the society. So I would like to present some of our educational events. So we have the Young ELSA Mentorship Program, and this is a forum to meet and receive support and advice from more senior EFSCAN members. And this project has been going on since 2017. In 2025, we had 12 pairs. And also, this project consists of two parts, the online part and also in the in-person meeting, which occurred in Helsinki. And you can see some of the pictures here. Also, every year during our Congress session, we have our Young EFSGAN Day. Today, this happened on the 14th of May in Helsinki, and we had the opportunity to learn more about research and about systematic reviews, meta-analysis, and peer review essentials. Also, we had the reviewers program, which was a great success, and we ended our Young Day with a session named Immersive Painting, and you can see from this picture that we had great fun. Also, this year we had a new session, a new Young EFSGAN session, and we had the chance to discuss clinical cases, very difficult cases for us with professionals. And we had a chance to receive advice from more senior members about our difficult cases. Also, every year we have the opportunity to meet the president, and you can see here our former and our current president, Dr. Ana Maria Stayan. Also, we have the EFSGAN Society organizes so many educational events. Here you have some of the upcoming schools, but also if you would like to learn more about the educational events that are organized by our society, you can go to our website, to the Knowledge Center, and then you can click on courses and you can find there so many of the educational events that EFSGAN organizes. Also, I would like to tell you more about the EFSGAN Research Academy. The deadline is very soon, is this Friday. And this Research Academy gives you the opportunity to build a strong foundation for a research-driven career. It consists of a two-year syllabus, and you have the online training, but also you can have the chance to go abroad and go to a research center and learn more. So if you would be interested in a more research driven career, then you can apply, and don't forget the deadline is very soon, is this Friday. But who we are, I would like to introduce our young EFSGAN committee members, and I will start with Anne-Marie, who is the chair of our society, and we have Vangelis, Petra, Francesca, Pinar, myself, Jose, you can see also, and we have our GIC Nutrition and HEPCOM representative, Giovanna, Harwin, and Benno, respectively. So if you're not trainee member yet, please join us. You have many benefits as a trainee member, from the subscription to JPGN online to access to EFSGAN research grants, awards, courses, and so on. So in order to become a member, you have to complete the application form you can find on the website. You have to fill in a CV and upload it, and also a letter of support from a full member not serving in the council. Also, you can find out more about our young society and also about the EFSGAN society on the EFSGAN app. And also you can find us on the social media on Instagram. So if you're not a follower yet, please follow us. Regarding our webinars, we have exciting new topics. In September and November, we are going to do a reviewers program, a reviewer session. We haven't actually decided yet on the date, but we are going to let you know very soon. And also on October 29th, we are going to talk about IBD, fertility, and pregnancy, a very interesting topic. So please join our upcoming Young EFSGAN webinars. And without further ado, I would like to let my colleague Jose introduce our special guest today, Dr. Junquera, who's going to talk about a very interesting topic. Thank you.
Thank you, Mara, for that complete summary of what everybody, every one of us, and what we do in the Young EFSGAN committee. I will very pleased and very happy to introduce Dr. Gutierrez, Carolina Gutierrez. She's a pediatric gastroenterologist and associated professor of pediatrics in Universidad Autónoma de Madrid, with a distinguished career in eosinophilic gastrointestinal diseases, particularly with eosinophilic esophagitis. She actually serves as the secretary in the EFSGAN eosinophilic gastrointestinal diseases working group, and played a key role in major international guidelines, including update pediatric management of esophagitis, eosinophilic esophagitis, and also joined with NASGAN and ESGAN guidelines. She is a principal investigator of the Spanish Registry of Pediatric Eosinophilic Esophagitis, but she is not only an exceptional professional, but also a very trusted colleague and an outstanding person that I'm very happy to have her to learn very much for her experience. You can go, Carolina. Thank you very much for helping us.
Yeah, thank you very much, Jose, for this very nice presentation, and also Mara and the rest of the EFSGAN committee for inviting me to share with you this, for me, very interesting topic. And also, I want to thank you, all the attendees that really are the young people in our society. I think you are very important. You are the future, and it is very important to establish alliances and also, of course, to support you. My talk is about nutritional management of eosinophilic gastrointestinal diseases. It's a problem that, as you know, is an emergent problem, and mainly I will begin with the eosinophilic esophagitis that, as you know, is the more frequent eosinophilic gastrointestinal disease. Really, this is just a little bit young disease that was identified in earliest 90s, and it was identified by a general surgeon and an adult gastroenterologist, Atwood and Dr. Strauman, but it was really a pediatrician, Dr. Kelly, who related this disease with food antigens. And this was a very important step and a seminal study that really help to understand what's going on in this disease. And as you may know, in this case series, he described a group of children with gastroesophageal reflux, or what was thought that it was gastroesophageal reflux, and esophageal eosinophilia that did not respond to medical and even in some cases surgical anti-reflux therapy, but responded to an elemental diet. And this was a very important step in the knowledge of the relation of food and eosinophilic esophagitis. From these earliest 90s, this disease really has, the incidence has exponentially increased and is more recognized, but also is really not only because we recognize it more, but because it really happens more. And now it's the most prevalent cause of chronic esophagitis and dysphagia and food impaction in children and adults. This is one of the latest systematic review about incidence and prevalence of EOE all over the world. And as you can see in the graph of the right, there's a constant increase in the prevalence. And so this chronic disease is going to be very important for us, and it is now really. So this is a slide just to summarize very briefly what is the cause and the mechanism that leads to eosinophilic esophagitis. And as you can see, food allergens are the main triggers. Maybe aeroallergens have a role in some patients, but this is not very frequent. And these allergens, in the end, what they do is they disrupt the epithelial barrier, and with different cytokines, alarmins, and also different cells that includes not only eosinophils, but also mast cells, that leads to esophageal inflammation, lamina propria fibrosis, esophageal dysmotility, and epithelial permeability. And this is the cause of the symptoms and also the cause of the progression of the disease in many patients to a fibrostenotic phenotype. So when we speak about diet, we speak about treating the cause of the disease. And this is very interesting. And of course, we as pediatricians that are dealing with children with a chronic disease that they will have many years with this disease, it is very interesting. Because our goals of treatment in this disease is not only in the short term to improve the symptoms, to improve, of course, endoscopic and histologic findings and resolve complications if there are complications such as stenosis or food impaction, but we have to prevent in the long-term recurrence, to prevent complications, mainly stenosis and others, and of course, one very important in pediatrics, malnutrition, but also we need to have the goal of improve the quality of life of our children. And then we have in the first step 3 different therapies. One is PPIs, the other one is swallow topical corticosteroids, and the other one is elimination diet. And they have pros and cons, and the decision to offer or to start one or the other should be a shared decision making process with the parents and the family and the patient, because they have different aspects and we have to take in account efficacy in the short and long term, safety, disease severity, impact in quality of life, long-term adherence, and also some predictive factors that we are trying to identify through research in recent years. But we have to take in account very, very carefully the patient and family preferences and lifestyle, and also, of course, the availability and cost. And then we have, in the beginning, and this is an old systematic review and meta-analysis, it's from 2014, in which the rates of histologic remission with different type of diets, it's shown. And as you see, the highest efficacy is achieved with elemental diet. It's about 91%. But of course, elemental diet is not suitable for a chronic disease and it has not a role really in the treatment of EOE at that time, just in very limited cases, for example, if there's a stenosis or very important dysphagia with malnutrition for a very short period of time. And then in the first studies, what was studied was the 6-food elimination diet, an empiric elimination diet, avoiding all the triggers that were more frequent in IgE-mediated food allergy that include milk, gluten, or wheat, eggs, legumes, fish and seafood and nuts. And of course, the rates of histologic remission were high, about 70%, but we will discuss later that the problem is that we don't have any test that can identify which one is the trigger in each patient. So in this process, what was performed was to eliminate all these 6 foods and then really assess the histologic status. And if there was a remission, then to introduce them sequentially to identify which one, or if sometimes it's more than one, were the triggers in that patient. As you can imagine, this is a very difficult process. It had an important impact in the nutritional status because all of these are really daily food. And then it has been evolved to less restrictive diets, as I will discuss later. And the targeted elimination diet that was tried using our current allergy test is really not accurate, and it's not recommended because the tests that we have that are mainly for IgE-mediated allergy really are not able to identify the trigger in each patient, and mainly they detect sensitization to these foods in the context of atopic background. These first studies using 6-food elimination diet were very important because they identified that the majority of patients had only one or maybe 2 triggers. So less restrictive diets were possible. And at the same time, the main triggers were in this order: dairy, milk, and to a lesser extent, wheat and eggs, and even less frequent nuts, legumes, and seafood. And these results have been observed in many studies, not only in Europe, but also in the USA and in Australia. And for example, in this other systematic review, as you can see, especially in pediatrics, dairy is the most important one, and then wheat and egg. So probably in the end, milk is really responsible in the majority of patients with eosinophilic esophagitis, or in a significant proportion of patients with eosinophilic esophagitis, either alone or associated to another antigen such as egg or gluten. This is also an update of the meta-analysis that I referred before. And what is important for me to highlight here, this is 6-food elimination diet. Efficacy was 61%. This was for food. It was milk, gluten, egg, and legumes. It was about 50%. And this one was collecting all the studies that used only one food, that was milk. And as you can see, the remission rate was about 50%. So the difference nowadays, summarizing the last studies, is not so important. And at the same time, even in these studies that have studied eliminating only milk, the histologic remission rate, as I said before, was about 50%. They are very different methodologically, and some of them are more rigorous and some less rigorous, but I would like to highlight that 2 of them were randomized controlled trials in adults and in children. In adults, it was 1 food versus 4 food, and in sorry, in adults it was 1 food versus 6 food, and in children it was 1 food versus 4 foods. And as you can see, the rates of histologic remission were 40%, 35%, but the most important thing was that they were the same than with 4 food elimination diet or 6 food elimination diet, probably highlighting that these more restrictive diets are very difficult to adhere, and so many patients cannot really do them properly. The last meta-analysis and systematic review is this one from 2024, and more or less the results are the same. As you can see here, this is the 6 food, about 64%, 4 foods, about 55%, and milk only 46%. So really what we think when we see these studies is what we should do with our patients to step up, to begin with cow's milk, and then to step in those motivated patients to a wider or more restrictive diet, or to begin with 6 food and then try to identify all patients from the 6 food. And this question that is really important was answered by a multi-center study done performed in Spain and in Italy, in which it included not only adults but also children. Patients with eosinophilic esophagitis were initiated a 2-food elimination diet with milk and wheat. Those that responded, then they were studied to see if it was milk or it was wheat. And those that did not respond were escalated to 4-food elimination diet. And in those that did not respond, they were escalated to a 6-food elimination diet, doing a step up. And the most important findings in this study were, in terms of the histologic remission rate, it was the same that was described in studies that individually study 2-food, 4-food, or 6-food elimination diet. 44% for 60% for 4, and about 80% for 6-food elimination diet. But there was a reduction in those that responded to 2 or to 4 foods. There was a reduction in the number of endoscopies needed in about 20%, and the time to identify the triggers. So really this approach showed us that this was an approach more appropriate to early identify adequate patients for diet. Because look at this part of the graph in the right, that are the number of foods that were responsible in those patients that did not respond to 2, were stepped up to 4, and did not respond to 4, and then were stepped up to 6. And as you can see, 50% of them had 5 triggers, 25% of them 4, and 25% 3. This means that in this chronic disease, these children, to be treated with a diet and to maintain the esophagus in histologic remission with no inflammation, they need 3 or 4 or 5 restrictions of foods that are really very common and used in daily life. So these patients really are not adequate for a diet, and they should go for medical therapy. So in terms of to step up or to top down, really the idea is to step up, because we are going to identify those patients that really are suitable for elimination diet. One very important aspect of the diet that has not been studied enough is the long-term efficacy. We assume that it's in the long term the diet is efficacious, but there are very few studies, mainly in adults, more of them with a 6-food elimination diet, and what has been shown is that there's sustained remission if they are compliant with the diet. But long-term adherence is a very important problem. In these studies that were also in adults with more restrictive diets, only 50% of them were adherent at 1 year of elimination diet. This emphasizes the idea that less restrictive is better for the patient because the adherence in the long term is going to be higher. And what is the safety of the elimination diet in eosinophilic esophagitis? Of course, it has not adverse events in the sense of that the adverse events that can be associated with medical therapy, but they can have an important impact on quality of life. Of course, children do not want to eat, for example, at school in the allergic table, as they named this table, because they are not with their friends. And of course, there's a restriction in their social life in a way. But also it can have a nutritional impact, especially with more restrictive diets. And even that these patients, some of them, they have had swallowing difficulties, and this has also evolved to a problem with feeding behavior. And so some patients have been described with ARFID after elimination diet in EOE. We have to keep that in mind to select the adequate patient. And also some cases of development of IgE-mediated food allergy to foods that have been eliminated because of EOE, and we will discuss this a little bit later. And we have to ask ourselves also if some patients are good candidates, for example, teenagers. This is a moment in life that is very difficult to adhere to the diet, or it may be, at least in some of them. Those patients that already had restrictions because of IgE food allergy, many of our patients are atopic and they have other allergies. And also if they have stenosis phenotype, because it has been shown that it's less effective than medical therapy, at least in adults. But what about the impact in quality of life? This is something that has been studied in a multi-center study in Spain with a specific questionnaire for eosinophilic esophagitis in an important proportion of patients. And as you can see, those with dietary had lower scores in terms of quality of life versus those that receive pharmacological treatment. In terms of patients' quality of life and parents' quality of life, and the factors that were associated with poor quality of life was diet. One of them, also frequency of symptoms, food allergies, etc. So we have to keep in mind that this could be more important for one patient than for the others. And there are many different ways to solve it, but it has an impact because food is in the center of our lives and especially of our social lives. In terms of new-onset IgE-mediated hypersensitivity reactions to eliminated food in EOE, this has been described. Patients that eliminated, for example, milk or wheat or soy, and after a period of elimination, then when it is reintroduced or in an accidental ingestion, they develop an IgE-mediated food reaction. We have to keep in mind that our patients are atopic, have atopic background, but this has been very rarely described. We should know that, but this is the summary of all the cases that have been described in the literature. And as you see, there are 9 children and 1 adult, mainly to milk and with different allergic background, some of them with past IgE-mediated allergy to the eliminated food. But as you can see, 7 of them had negative IgE tests previous to elimination diet. So this is just to highlight that we have to keep in mind that this can happen. And if the child is very atopic, maybe it is worth it to perform an IgE test and to do a control introduction to avoid any of these reactions at home. Although I have mentioned before, these are very rare, but they have been described. So probably we have to think about how to promote the adherence to the diet, and also to avoid not being in contact with the protein so that this type of IgE reactions can occur in the future. And there are, especially with milk, there are some evidence with baked milk. I didn't put it in the slide, but I can tell you that there are 2 small studies showing that many of these patients that it is milk who induce the eosinophilic esophagitis, they can tolerate baked milk. And also, this is a study that is a very pilot study with only 18 adults, but it's very interesting because the idea is very challenging, and I think it should be research in the future. That is that these patients, adult patients that had milk trigger EOE, they consumed sterilized milk. The difference between sterilized and UHT milk is that in sterilized milk, there's less temperature, more than 100, but for 20 minutes. In the UHT treatment, it's very high, 145 degrees, but only 2 to 10 seconds. As you can see in the protein profile here by electrophoresis, the first one is control, then 1 is UHT, and 2 is sterilized. And you can see that the higher the peptides with higher molecular weight are avoided, especially in sterilized milk. And in this study, a small pilot study, 2/3 of these adults tolerated sterilized milk that it's in the supermarket, that you can buy in some supermarkets, ingesting as 200 milliliters twice a day, so significantly. And this can help also, as I said before, to adhere and also to avoid other reactions such as IgE-mediated reactions. So we have pros for the dietary treatment, that is a systemic treatment. It's not a topical one like corticosteroids. It's a systemic one that targets directly the cause of the disease, that avoids long-term drug side effects. That's very important for our pediatric patients that have a chronic disease, and they are going to have a long-term period of time taking pills or taking drugs, medical therapy. But the cons that we have now are that there are no tests available to identify the responsible food in each patient. We need eliminate and provocate to identify them. It has impact on quality of life, as I said before, especially if there are other restrictions, and sometimes it's difficult to adhere to the treatment. But where is it then positioned in our updated ESGAN guideline? Really, it is positioned at the same level than the other 2 standard first-line therapies that are topical steroids and PPIs. So really, it's a very interesting and suitable option for many patients, but we have to find the right patient. And this is a summary of the pros and cons of every different type of standard first-line treatment in EOE. I'm not going through them just to mention that, of course, all of them have pros and have cons, and I have said before that we have to discuss them with our patients and families and decide what is the best option for the patient we have, taking into account different characteristics of the patient. For example, to select the dietary treatment, we have to select the right patient that is motivated. We must say that diet therapy usually is preferred by parents and pediatricians, but not for by children. And this is something important. Some ages, as I mentioned before, are not the best ones. We have to take into account the lifestyle. If the family is a family that they eat at home, or they really cook and they know and they are very willing to cook with restrictions. The endoscopy acceptance, in terms that we have to assess if it is working and if the disease recurs after introducing the food again. Of course, no other dietary restrictions because we add another one. And we have to keep in mind also the nutritional situation and at that moment. If there's malnourishment, probably is not the best option to initiate. And also if there's any restrictive behavior. But many patients really are very suitable candidates and they can achieve this important goal. But for that, we need to provide support material. It's also very important to have the support of the dietitian if available. Here, for example, we have the support material that we have elaborated in our working group in the Spanish Society and is available for every pediatric gastroenterologist in the country. And we have to select the appropriate diet, and the recommended is eliminate just probably one milk or maybe two, and then to assess if this works, and to step up only in very highly motivated patients and families. But I mentioned before that it is a very difficult process, and in the end, many of them have a lot of food triggers. So 1 or 2 foods are really the recommended diet right now. If we move beyond the esophagus, that situation is a little bit more difficult because these diseases are less frequent and not so known as eosinophilic esophagitis. This was the first international consensus recommendations for the nomenclature of these diseases, just to try to name these diseases in the same way with the same criteria, so we can really move forward in clinical and basic research and knowledge. And as you can see, now we don't speak about eosinophilic gastroenteritis. We speak about eosinophilic gastritis when the inflammation is located in the stomach, enteritis when it's located in the small intestine, duodenitis, jejunitis, or ileitis, and colitis when it affects the colon. Of course, sometimes it can be more than one segment, and even it can be simultaneously or progressively affected more than one segment. And also they can have esophageal involvement. But we need to, if that is the case, then we will describe eosinophilic gastritis with esophageal involvement or eosinophilic gastritis plus eosinophilic duodenitis. And then, as Jose mentioned before, this was a very important effort from NASGAN and ESGAN, promoted especially from ESGAN, to try to start with the first guidelines, at least for diagnosis, that can help us to talk about the same and to improve the care of these patients. And as you see in the definition, these are chronic immune-mediated disorders with eosinophilic inflammation of the mucosa, but not only the mucosa, they can affect also the serosa and the muscular layer, that can lead to organ dysfunction. And for the diagnosis, we need the clinical symptoms and the histologic inflammation. There was also a very important effort with pathologists to try to come up with a consensus of the threshold of eosinophils per high power field or per square millimeter in each segment of the GI tract that can be pathologic. As you know, in the esophagus, there are no eosinophils in the normal stage, but the eosinophils are normal cells that are present in the rest of the GI tract because they act in the immune homeostasis and against parasites, etc. And this was what came up in terms of the eosinophil counts. And the symptoms are very different. And this is a very long list, a very busy slide. I just want to mention that mainly eosinophilic gastritis and eosinophilic duodenitis are the most frequent pictures, or the more frequent diseases. And usually they can have vomiting, abdominal pain, weight loss, early satiety, hematemesis, but also iron deficiency anemia. They can have very important nutrient or micronutrient deficiencies, also protein loss with edema and hypoalbuminemia. So of course, this can cause nutritional problems. And this eosinophilic gastritis and eosinophilic duodenitis, in the pathogenesis, it has been shown by American colleagues with a transcriptome that they are very correlated or very similar to eosinophilic esophagitis in terms that there is a T2 immune response. But this is not the case of eosinophilic colitis. That probably is a different pattern, and it's more related with cell apoptosis. So really, eosinophilic gastritis and enteritis or duodenitis are the ones that may be treated with elimination diet. But we have very, very few evidence. I'm going through some of the studies, mainly retrospective, some of them very old, and with small number of patients. For example, this one in 2006 from Mirna Tejade in 6 children with eosinophilic gastritis and duodenitis and protein-losing enteropathy, in which an elemental diet with some low allergenic solids in 3 cases, in 6 of them, in the 6 of them, there was resolution of symptoms and hypoalbuminemia. This highlights that this disease may be also related to food antigens. And this other one, 30 children with eosinophilic gastritis. In 17 of them, there was a dietary restriction that was very different, elemental diet with consumption of different foods between 1 to 12, only with red meat, or eliminating only 1 to 3 foods. And there was clinical response in 82% of them, and an important histological response in 11 of 40. In neither of these studies, there was a correlation with IgA-mediated allergic tests, such as it happens in eosinophilic esophagitis. Other retrospective studies in 20 children with concomitant treatment with PPI, so it's more difficult to really assess the results. And there was also improvements in clinical endoscopic and histologic findings. And the last one that is very old, 1984, really this is a study in which they included 12 children, and they observed that those that were really very small, I mean infants with eosinophilic gastritis, that many of them, the clinical symptom, the main clinical symptom is hematemesis. The majority of them really respond to milk elimination, and they can tolerate between 30 to 36 months. It's a clinical picture that is different than when the eosinophilic gastritis onset is at older ages. This is also an old study, 2015, by Alfredo Lucendo. It was not a meta-analysis, of course, it was not a systematic review because of the data were not very robust, and the studies were mainly case series and retrospective studies. But the elemental diet really led to clinical improvements in a lot of patients in different studies, but the histological response was assessed in only 6 patients. And empirical elimination diet, eliminating milk or eliminating 6 foods, led to clinical improvement in some studies without assessing endoscopic or histologic status. And then there's this new study from 2023. I think it's an important one because it could be more or less the resemblance of what happened in eosinophilic esophagitis with the study by Kelly in 1995. And this is a prospective study in adults with eosinophilic gastritis or eosinophilic enteritis. And only 15 patients, but they received only elemental diet for 6 weeks and were assessed clinically, endoscopically, and histologically. And as you can see, there was a response in all the outcomes. And even in the molecular profile, in the transcriptome, there was a response. So this study really supports that therapy could be important and useful in eosinophilic gastritis and enteritis patients, and also provides insights into disease mechanism and into the role of food allergens in disease pathogenesis. And moreover, when these adult patients that were in clinical, histological, and endoscopic remission with elemental diet received or reintroduced different foods, as you can see in these graphs, the eosinophilic infiltration recurred in the stomach and in the duodenum, and also in the peripheral blood. In the contrast, what happened in eosinophilic esophagitis, that the eosinophil count in peripheral blood is not so important or not so informative in these diseases, eosinophilic gastritis or duodenitis, when they are in a burst, when they have symptoms, when they have inflammation. Many times there's the peripheral eosinophil count increases, and then when they are better or in response, the eosinophil peripheral count decrease. So to summarize, I'm happy then to answer the questions you may have. My take-home messages will be that dietary treatment is very important in eosinophilic esophagitis because it targets the cause of the disease, that empirical diets are of choice, starting with eliminating of one or maybe two, and stepping up only in those patients and families that are very highly motivated, that the most commonly involved foods are milk, and to a lesser extent, gluten and eggs. And for the success of the dietetic support and the choice of the right patient are essential. And regarding gastritis and eosinophilic enteritis, there's evidence, although scant, of the role of food allergens, and there are retrospective and now other prospective studies supporting the efficacy of elemental and maybe empiric diets based primarily on clinical evaluation and to a lesser extent on endoscopic and histological findings. And for the future, there are many, many areas of research that we need to collaborate and to try to answer. And one is with our colleagues, the allergists, to develop new allergic tests that allow a personalized and non-invasive approach, and also to study the long-term tolerance of intact or modified feed that may improve the long-term adherence and quality of life of our patients. And thank you very much for your attention.
Thank you so much for this great presentation. We already have so many questions. I hope we'll have time for all of them. So I would like to start with the first question. It comes from Matilde. Some few children develop EOE after reintroducing food they were allergic to earlier in their life. Do you think this is a manifestation of an allergy or a condition that would have happened anyway and food just triggered it? And would you keep avoiding this food in the diet?
I suppose Matilde is referring to oral immunotherapy, to this technique that, okay. So this is a very interesting question, and there's some controversy because, as you know, there's especially one study that showed that even 30% of allergic children may have esophageal eosinophilia without symptoms, performing endoscopy before the oral immunotherapy. So this can be there, but quiescent, asymptomatic, and so not always the trigger is the food that is incorporated in the oral immunotherapy. Of course, when we see a patient that is under oral immunotherapy and he or she develops symptoms of esophageal dysfunction, then if in the scope there's eosinophilic esophagitis, we have to treat these patients. It may be new onset EOE, or it may be just there, and now the symptoms are more present. But in terms of avoiding or eliminating that food, I will really discuss that very carefully with the allergist. We have to keep in mind what are the symptoms that the patient have, if there's a life risk situation in terms of eliminating the food again, because if the patient were having anaphylactic reactions to that food, and that was the reason to start oral immunotherapy, I will balance to avoid completely the food, because in an accidental ingestion, he or she may have a very important manifestation, life risk manifestation, and then in that situation, probably I will go for medical therapy and continue with the food as tolerated to avoid a risky situation to that child in discussion with the allergist. If that is not the situation, probably we can try to eliminate the food and, of course, confirm that there's a resolution of the esophageal inflammation, because it may be or it may not. Because sometimes in the beginning, when we start observing this situation, we eliminated the food in the majority of cases, and some of them really continue with the esophageal inflammation.
Thank you, Carolina. Very nice your presentation. I think I'm going to try to combine too much questions because we have a lot. Thank you very much. There's questions about your experience. How many weeks do you think it's important to do the exclusion diet? And in your experience also, if you start with one or with two food elimination diet, because I know both are good, but in your experience, how do you think we can start?
Okay, thank you very much for the question. First, in terms of the time, I think we started doing 8 weeks for everything, especially because the level of restriction was so high that it was impossible for that patients to maintain this highly restricted diet for more time. But now that we are using less restricted diets, I usually go for 12 months, because, I mean, if the patient is doing well and there's no problems of any clinical symptom in that period of, I don't know, food impaction or whatever, then we have to wait for the inflammation to resolve. We don't have to be so quick, because maybe what we are going to see is a reduction, but we have to keep in mind that sometimes we need more time. So I usually go to 12 weeks, 3 months, sometimes 4 months, depending. And I start with milk. I start eliminating only milk. And as Jose know, we are also performing a multi-center study in Spain, a prospective one, eliminating only milk and doing prospectively all the tests, clinical scores, endoscopic, histologic, etc. And we are observing about 50% of efficacy, that is 50%. That is more or less what it has been described. And only in those that really are very motivated, I opt to step up. I think we can do, of course, if you want milk and egg or milk and wheat, but it's more difficult, and the level or the proportion of what you obtain is not so high, and it's really more complicated. So I think that for our kids to start only eliminating milk is probably the best option.
Great. Thank you. And just for finishing this question, do you think that any unaware contaminant, for example, in any other foods, could also be a cause of unresponse in the diet?
You mean cross-contamination?
Cross-contamination, yeah, and very small contamination, not very like, you know?
I don't know. I mean, that's very difficult to answer, because really what we have is the endoscopy and the biopsies, and then to know to what extent this can be the reason needs to do a very strict diet and then to do an endoscopy. So it's difficult to prove. I can tell you what I do. That is that in the first part, in the induction phase, I really advise them to go for a very strict diet to avoid everything, cross-contamination, and even those foods or those that say that they can have traces. Then we eliminate everything with the help of the dietitian. But when they are in remission, of course, they do not eat milk or food that milk is the ingredient, but we allow them to take or to ingest these foods that may contain traces, because really these are not so important and they don't trigger the disease in our experience.
Right.
So this is my approach.
Someone also asks about cheat days, if you allow cheat days.
Yeah. I mean, this is something very important, and I think it's possible, but we have to be very cautious because, for example, I can say if I have a teenager or a patient that is in milk elimination diet and he's going for a camp in, I don't know, in abroad, and of course the diet is not going to be feasible, then I can tell them to have normal lunch and or normal food, and then I put them in a medical therapy. In special situations, it can be, for example, I don't know if it's a celebration. It may be a birthday, something like that. But you know how children behave. You give this and they ask for more and more and more and more. And sometimes you get in a situation in which you are not sure that we are really maintaining the esophagus without inflammation. So you can, of course, give some holidays of the diet, but with caution and talking to the family, not to go further in order to avoid to ingest so many food antigen that in the end it's not working.
That's good. I think we have one more time for just this question. Maybe it is interesting because Anne-Marie asked us if you have come across a patient who has been investigated for celiac disease and who are found to have eosinophilic esophagitis and endoscopy as an incidental finding. Do you consider if wheat could be the potential bearing in the mind of the pathophysiology is not the same, and if you come across with this phenomenon quite often?
Yeah, that's a frequent, not so frequent now because we don't scope so much celiac patients now because of the highly accuracy of our antibodies. But yes, we see some patients that when we scope, we see endoscopic findings and histological findings, and they have not complained of esophageal dysfunction. The first thing I think you have to do is to really assess if there is not any esophageal dysfunction, because sometimes these are children that avoid some textures, that avoid some foods, that cut the food in very small pieces, that the food time is very prolonged. So in the end, they are not really asymptomatic. They have adopted mechanisms to eat in another way. And of course, when I have to eliminate one food in these patients, that is the gluten. So in many cases, what I do is I try to see, although the probability is low, if they are not very symptomatic, to see if eliminating wheat, I can achieve the esophageal inflammation resolution. This is not very frequent. It is, of course, about 12, 15%, but it can happen. So that's a chance. And if it is not the case, then I will discuss the other different treatments that we have, medical or even diet if they want, and I will eliminate milk. But although there are different mechanisms, they can be the same trigger in one patient for celiac disease and for eosinophilic esophagitis. It is not common, but it can happen.
Thank you.
Thank you. So unfortunately, our time is up. Maybe we can ask like one last question. Would that be okay?
Yeah, for me it's okay if it's no problem.
We have another question from Pinar. How do you see the role of diet in the future management of eosinophilic GI disorders? Do you think it will remain central to treatment or become more of an adjunct pharmacological approaches?
Okay, that's a very important question. I think eosinophilic gastrointestinal disorders beyond the esophagus are very complex. As I said before, eosinophilic gastritis, for example, in infants, really are very responsive to milk elimination. So, of course, in these infants, in many of them, you can try milk elimination, and that can really be the solution. But we have many problems in implementing the elimination diet in these diseases, in terms that we don't have non-invasive tests or tools to assess if eliminating that food is really working, because we don't really have now the outcome, the goal. Of course, we try the endoscopic improvement and histologic improvement, but sometimes, for example, if it's a jejunitis, that's very difficult to assess, for example. So I think that it's going to be a difficult path, and probably pharmacologic treatment, systemic pharmacologic treatment, and probably biologic therapy will help these patients more than diet. But there's a wide spectrum of severity and a wide spectrum of clinical pictures. So probably in a subset of patients, it will be very valuable.
Thank you so much for this great presentation. I hope you also enjoyed it.
Yes, very much, because there was a lot of discussion and very interesting questions.
Yeah, thank you very much, Carolina.
Thank you for inviting me.
And I would also like to thank all the participants for joining us again. And we can wait to see you again next month to another interesting webinar session. So thank you again, everyone, and have a lovely evening.
Thank you, Mara. Thank you, Carolina, again. It was great. Thank you very much.
Bye.
Thank you.
Bye.